I'm going to try to take you on a little bit of a whirlwind of what we've been through in the last really almost 25 years at Memorial, trying to develop paradigms that were very easy for people in the community to be able to look at a spine tumor, a metastatic tumor, and be able to make decisions about it and then treat it. It's a massive problem in the cancer population. 20% of cancer patients will develop spine metastases over the course of their illness, and we've seen an increased number over the past 15 years or so as MR and FDG PET have improved detection and the systemic treatments have improved survival. And while the biologics and checkpoint inhibitors are extending survival for virtually every cancer, they're much more effective for visceral than for bone disease. Additionally, what has recently happened is that stereotactic radiosurgery has improved overall survival for oligometastatic disease, defined as 1 to 5 tumors. 2 trials came out. One was a SABRE-COMET trial, which is a randomized open-label trial that compared standard therapy plus radiosurgery, and there was a significant overall survival advantage. And then in our study, the PISA trial, looking at bone tumors only at 24 gray, where you gave an ablative dose of radiation, we actually showed an overall improved survival. So treating spine metastases becomes critically important to overall survival in the cancer population. Despite that, the goals of treatment for metastatic disease remain palliative. We want to improve or maintain neurologic function, achieve local tumor control, mechanical stability, pain relief, and ultimately improve quality of life. And if we end up like that patient on the left who got a great return to quality of life paddling on this river, we've done our job well. It's this other thing that is our nightmare that we're trying to prevent in every possible way. This was actually a Pancoast tumor that got neoadjuvant chemoradiation, and the skin changes are probably radiation recall, that they had some combination of toxicity from radiation chemotherapy and then failed fixation. And obviously in the metastatic population, that's a very, I'm really bad at this. I was looking at other people and thought, but ultimately needed that big fix. And again, in the metastatic population, that's a terrible outcome and really not something that we ever want to see if we can avoid it. It turns out that even as surgeons, we recognize as the single greatest advance in the treatment of metastatic disease over the past decade has been the evolution and integration of this stereotactic radiosurgery. It's defined as high-dose perfraction conformal radiation, typically given a 16 to 24 gray single fraction or 8 to 10 gray times 3 fractions. And compared to conventional external beam, which is usually given as 3 gray times 10 fractions, radiosurgery actually obviously has a shorter treatment time, but you can actually give a cytotoxic ablative tumoral dose, and that fundamentally changed our treatment paradigms, including the indications for and type of surgery that we do. And that led to this concept of what we'll talk about, separation surgery. There have been major advances in radiosurgery over the past decade, including technological, defining tumoricidal doses and dose constraints for organs at risk, and even defining the radiobiology of radiosurgery. It turned out that this patient population is incredibly complicated, and when I got to Memorial almost, again, 25 years ago, I had no idea how to make decisions about these patients. And it turned out that there are probably 4 sentinel decisions that you need to make on every patient to decide best treatment, and that became known as the NOMS decision framework: neurologic, oncologic, mechanical stability, and systemic disease to decide best treatment. And we've left it more as a decision framework than an algorithm because it allows us to integrate new technologies and evidence-based medicine as they become available. What we're principally going to talk about today are the neurologic and oncologic indications, which are made in combination. From a neurologic perspective, we're very concerned about whether a patient has myelopathy, functional radiculopathy, but a lot of the decisions are principally made on the degree of epidural spinal cord compression. From an oncologic standpoint, the degree of epidural spinal cord compression, there's a scoring system that was validated, which actually usually goes by it's called the Bilsky ESCC score, because I was the first author on this paper. And typically at our institution, we call it the ESCC score, but when I'm at home, I call it the me score because it's named after me. And it was critically important at the time that we did this because people use all kinds of definitions for what constituted high-grade cord compression, and as we were trying to define what we could treat with radiosurgery, we had to have a validated scoring system that everybody could use and recognize. In the scoring system, 0 is bone only. 1, A, B, and C are different degrees of epidural impingement without spinal cord compression. 2 is spinal cord compression, but CSF is seen. and 3 spinal cord compression, no CSF seen. And traditionally, the 2s and 3s have been considered high-grade cord compression, although that's beginning to change now. From an oncologic standpoint, what we're really talking about is how do we get local tumor control? And I will tell you that it's not predicated on how much tumor you take out, but it's completely predicated on the radiation response. And radiosensitivity has been completely redefined as we've transitioned from conventional external beam radiation to radiosurgery. And now we have brachytherapy, P32 plaques to clear dural margins, and high-dose iridium afterloaded catheters for recurrent bone disease. Mechanical instability is a separate assessment in this patient population. Why? Because no amount of radiation will stabilize an unstable spine. And once you recognize it, those patients are often candidates for kyphovertebroplasty, percutaneous pedicle screws, or open surgery. The SINS criteria was developed to define instability in the neoplastic setting. Most of you know these criteria well, but once you define mechanical instability, they're no longer a candidate for radiation to cure that mechanical pain. They need some kind of procedure or bracing to stabilize the spine. And finally, the last issue is what are the systemic and medical comorbidities that impact on our ability to treat? How sick is that patient? What's their extended disease that impacts your ability to either give surgery or radiation? Much of this is predicated on the expected survival in these patients. In this decade of biologics and checkpoint inhibitors, there's virtually a new biologic or checkpoint inhibitor for every single cancer. And so a decade ago, we knew exactly when patients how long they were going to survive with non-small cell lung cancer. And then all these new agents came in and sort of tilted it on the head. For melanoma, you can see with a single biologic nivolumab tripled the survival compared to standard chemotherapy. And again, that exists for most. So we've all now had to go to other kinds of predictive survival metrics, such as the SORG nomogram, which was developed by Joe Schwab at Harvard to predict these in the light of all these new biologic checkpoint inhibitors that will treat tumors like melanoma and renal cell, where again, 10 years ago, they virtually had no systemic treatment. Now there are 30 agents per, and they're all effective in some way. And so you have to be able to make decisions in that patient population. It turns out that in the literature, there was very little that looked at differential radiosensitivity based on tumor histology, but what's there was remarkably consistent. There are radiosensitive tumors to conventional radiation, such as hematologic malignancies, breast and prostate cancer, but most of the solid tumors are radioresistant. For the radiosensitive tumors, we have 2-year local control rates of 86% versus the radioresistant tumors, where 2-year local control rates are 30%, and median durable responses in some of these tumors are only at 3 months. With stereotactic radiosurgery, we overcome that radioresistance that you see with conventional radiation, and all tumors essentially become radiosensitive. In our series, which I'll show you in a minute, we have 2-year local control rates now of 98%, completely histology independent. You overcome radioresistance with high-dose perfraction radiation. Here's a patient with multiple myeloma with very high-grade cord compression at T10. This is a very radiosensitive tumor. This patient was put on high-dose steroids, got 3 grade times 10, and re-imaged 2 weeks after the radiation. You can see the tumor completely apoptosed, decompressing the spinal cord. And I will tell you that you can't do better than that with surgery. And so most of these patients will be put on high-dose steroids and then irradiated with just 30 gray and 10 fractions. So there is a role for conventional radiation in modern treatment paradigms for radiosensitive tumors, regardless of the degree of cord compression. But for the radioresistant tumors with minimal or no spinal cord compression, we typically go straight to stereotactic radiosurgery. There is a plethora of data showing great outcomes with radiosurgery. Here's our series of a little over 800 tumors, mostly for radioresistant tumor histologies with a median follow-up of a little over 2 years. All were contoured according to Radiosurgery Consortium guidelines. The prescription dose was 18 to 26 gray, single fraction, 1 dose of radiation, but dose was analyzed as a continuous variable, and an optimal cut point was set to establish a low versus high dose cohort. The median dose to the planning target volume in the low dose cohort was 16.4 gray versus the high dose cohort, 22.4 gray. The only significant factor in the incidence of local failure was the dose of radiation. In the low dose cohort at a year, it was pretty remarkable. We only had 5% failure rate, again, histology independent, versus the high-dose cohort at 22.4 gray was 0.41%. But at 4 years, it increased to 20% in the low-dose cohort versus only 2.1% in the high-dose cohort. And again, remember, in this radioresistant tumor histology, we were seeing durable responses of 3 months and 2-year local control rates of 30%. So we overcome that with this massively high dose of radiation. And again, no association with radioresistant tumor histology or the tumor volume. So how did that change our treatment paradigms? Well, here's a patient with a T10 solitary renal cell metastases at T10, ESCC score 1B, so epidural impingement, but no spinal cord compression. And if you use a Tomita scoring system, this would get a Tomita score of 4, and the recommendation would be for an en bloc resection of that tumor, much like we show with the primary tumors. Operative times of over 15 hours, massive blood loss, and actually relatively poor tumor control and no ability to impact metastatic disease. Today, we give 1 dose of radiosurgery. Now with volumetric arc therapy, it's 10 minutes of treatment and no morbidity. And so obviously this treatment paradigm had to change. For most of the world, in Europe they still do some en bloc. I think in the US it's incredibly unusual to see a patient like this go for en bloc resection over radiosurgery currently. Much of the last decade was really spent trying to define dose constraints for organs at risk. When you give this massively high ablative dose, it's much higher than most of the organs around that area can treat. The biggest cord constraint to treatment is obviously the spinal cord, and at cord D max, a maximum point dose on the cord of 14 gray, we have less than a 0.5% chance of creating myelitis. But it's that dose constraint that really prevents us from treating high-grade cord compression. And that's based on a lot of different factors. One is that in a dose failure analysis by Mike Lovelock at our institution, all local failures got less than 15 gray to some percentage of the planning target volume. So if we have a cord max dose of 14 gray with a 10% per millimeter fall off, then either we give a cytotoxic tumoral dose and hurt the spinal cord, or we underdose at the margin of the cord where we need the greatest control. Secondly, the resolution of that soft tissue takes months, not days, like I showed you with the myeloma, a very radiosensitive tumor, and so you get no effective immediate decompression of the epidural space. And finally, Sam Root tried radiosurgery for high-grade cord compression using single fraction radiation, typically 16 gray, and despite a 50% loss to follow-up, patients, we don't know what happened to them, 20% of the radio-resistant patients had neurologic progression. And so, at least at the time that that was published, which was 2010, we didn't think we could treat the grade 2s and 3s with radiosurgery. And then we got a little braver because we had a lot of patients who were really sick who had high-grade cord compression with radioresistant tumor and weren't candidates for surgery. And so we looked at our own series of patients where instead of giving single fraction radiation, we gave hypofractionated 8 to 10 gray times 3. And we saw that at least in the grade 2s, the 1 and 2 year cumulative incidence of local failure was 10%, increased to 22% at 2 years. So all of a sudden, those patients who weren't really candidates for surgery or separation surgery or some kind of decompression before surgery, if we hypofractionated the radiation, we gave up 10% control, but ultimately we could get them to effective radiation and not allow them to progress to neurologic injury. Can we treat grade 3s? Well, currently probably not. But there's a lot of technology that's going to come to bear that may allow us to do that. One of them is volumetric arc therapy, which is much more conformal than what we've traditionally used. There's a relaxing the spinal cord constraint, so at least in the single fraction, people are now using a cord max dose of 16 gray instead of 14 gray. And again, if we hypofractionate that 8 to 10 gray times 3, it'll improve our therapeutic window and potentially allow us to spare spinal cord tolerance. The next iteration is we do think that there will be radiosensitizers, so you can give a lower dose and get a much more effective treatment. One is there's a lot of evidence that TKI with a lot of VEGF inhibition, such as pazopanib and axitinib, act as radiosensitizers. So a lot of experimental evidence for that and some clinical evidence out of Cleveland Clinic. And then we like the combination of stereotactic radiosurgery and checkpoint inhibitors. One thing it does is it gives what's called the abscopal effect, where you give local radiation and get a systemic effect. And we think we see that about 20% of the time, again, owing to this concept that you impact systemic disease control with local radiation. But it can also augment local tumor control. And here's a patient with renal cell who had been twice irradiated and failed, couldn't get out of the wheelchair, had an extraordinary amount of pain. And Josh Yamada, our radiation oncologist, didn't want to give up on this young girl, and so he irradiated the center core of that tumor. It was a dose that was significantly too low to treat that tumor, but the patient was maintained on 2 checkpoint inhibitors, nivolumab and ipilimumab. At 1 month, you can see the tumor completely necrosed, and by 2 months the DCE images, which we look at for disease control when completely cold. So this combination therapy of radiation and either VEGF TKI or checkpoint inhibitors may be very effective at allowing us to lower the dose and treat higher grade cord compression. Ultimately today, high grade cord compression with radio-resistant tumor, however, continues to require surgery followed by radiation therapy. And that data is based largely on the Patchell data published in Lancet 2005. It was a prospective randomized trial of solid tumors looking high-grade cord compression with myelopathy, but the myelopathy could be simply biologic back pain. They compared surgery plus conventional external beam to conventional external beam alone, and rightly they excluded the hematologic malignancies. In every outcome variable, surgery was better than radiation alone. And based on that and a number of other studies, a strong recommendation is made for patients with high-grade cord compression due to solid tumor malignancy undergo surgical decompression stabilization followed by radiation therapy. The question became what kind of surgery and what kind of radiation. With the integration of stereotactic radiosurgery, the surgical goals of spinal cord decompression for neurologic salvage and screw rod systems to provide spinal stability remain the same. What changed is the oncology. Again, local tumor control is completely predicated on the radiation response. When we use conventional external beam radiation as a postoperative adjuvant, we often did these maximally cytoreductive surgeries. We tried to take out everything, do a gross total resection, or even this en bloc resection, because we had no faith that conventional radiation would control the tumor in the postoperative setting. With radiosurgery, maybe the only goal needs to be to reconstitute the thecal sac to create a better target for the radiation, which is the knowledge, again, that we have these radio-resistant tumors respond dramatically well to radiosurgery. And here's a patient, and that led to this concept of separation surgery, just give room for radiation. Here's an 86-year-old papillary thyroid AGC, very high cord compression with 3-level vertebral body disease. And I would submit to you there's no way to get this patient through a 3-level front-back surgery to decompress the spinal cord and try to get control. And so we started doing what's called separation surgery, which is simply a long posterior fusion, and then we take a high-speed drill and drill off the lamina, superior and inferior facet joint, and pedicle. We start at normal dural planes, and we strip the tumor off of the dura and take out the PLL to affect a margin on the anterior dural plane. Ultimately, what we're trying to do is take this very high-grade cord compression and create a circumferential decompression simply to create a better target for the radiation. We leave all this vertebral body tumor behind. We do long posterior segmental fixation. We take this patient 8 grade times 3, fully ambulatory, 2 years out with well-controlled disease. We gave this patient a surgery that she could tolerate and then effectively gave radiation to control the disease. What's the data on conventional external beam radiation as a postoperative adjuvant? Well, there's very little in the literature that actually followed patients longitudinally. This is a single series from Clay Camp Stanley published in 1998 of 101 patients with very aggressive surgery followed by conventional external beam radiation as a postoperative adjuvant. And with that aggressive surgery, conventional external beam, the local control was only 30% at a year. If you lived long enough, everybody recurred, and the biggest predictor of recurrence was tumor histology. If you had radio-resistant tumor histology, you weren't going to control the disease. Here's our series of 186 patients that underwent this very simple separation surgery followed by radiosurgery. Most patients were treated for high-grade cord compression with radio-resistant tumor histologies, and 50% had failed prior radiation. There are 3-dose strategies: high-dose single fraction, high-dose hypofractionated, and low-dose hypofractionated. The 1-year cumulative incidence of recurrence was 16%, but if we gave a high enough dose single or high-dose hypofractionated, we had less than 10% recurrence at a year. There were no neurologic complications associated with the radiation. And again, we overcame radioresistance with high-dose per fraction radiation. Overall, 75% of our non-ambulatory patients regained the ability to walk, and overall 90% were ambulatory. We talked about PROs a little bit earlier today, and using this technique of separation surgery followed by stereotactic radiosurgery, patients improved dramatically in BPI for pain and in the MEDACI for general activity. Why do we like separation surgery over what we traditionally use with these really aggressive approaches such as vertebrectomy? These are very short operating times. If you tried to take this tumor out grossly, this would be a 6 or 8 hour operation and you'd have to go through the chest. With separation surgery, remember, all we have to do is reconstitute the thecal sac and leave the remainder of that tumor for radiation. So we can do those surgeries in a couple of hours. We can do an emergency surgery. We don't need access surgeons in the middle of the night. Is a decreased morbidity when you don't have to go anterior transcavitary, particularly in cancer patients who have often had other surgeries. And we can actually do a better and safer epidural decompression because we can always start from normal dural planes and strip the tumor away. Here's a reduction in approach morbidity at C1-2. This is a patient with a low-grade chondrosarcoma, circumferential bone disease, and the best approach for this is a transmandibular osteotomy to get access to this tumor. Here you can see the mandible's been split. Here's the hypoglossal nerve and the tumor here. We actually put a cage in front. This patient needed to be pegged and trach for 2 weeks after the surgery, and then at 7 years to hiss the esophagus and trachea, and we were looking at the cage to the mouth. You can't do that to a metastatic patient. You can certainly, at least in the day that we did this, it was justified for a tumor like this, and I'll show you hopefully on Saturday why we're becoming less aggressive with the primary tumors as well. But here's that same location of a tumor, patient 33-year-old. She had multiple myomectomies for leiomyomas and finally got pregnant. She tripped on an airplane jetway and was actually acutely quadriplegic. And you can see this massive tumor in the posterior pharynx abutting into the spinal canal. And there's no way, again, to do a transmandibular osteotomy on a patient who's 3 months pregnant and quadriplegic. And so we simply did separation surgery with a occipitocervical fixation. By the grace of goodness, we recovered to normal neurologic function by 2 months. And this ended up being a low-grade leiomyosarcoma. So one of those tumors they took out in her uterus ended up being sarcoma. At that point, we weren't treating sarcomas with single fraction radiation, but we used photon beam therapy to give her 66 and 33 fractions. And today we do a lot of radiosurgery for sarcoma, but at the time we didn't. Here's the baby who was born 3 months after at 6 months. Here's the tumor we left behind after the separation surgery. And after simple radiation, the tumor is completely gone. This is her 12-year follow-up film. It's not about the amount of tumor you take out. It's about their response to therapy that ultimately defines their outcome. We've gotten a lot of criticism that if we don't formally reconstruct the anterior column, these patients will fall apart. Here's a series of 318 patients that underwent separation surgery. If we take out more than 50% of the vertebral body, we will put cement into that space, but our fixation failure rate was only 2.8% that needed reinstrumentation. So it's a very effective strategy in this patient population. Traditionally, we've gone long on the posterior constructs in order to distribute load and osteoporotic bone, and because if they progress tumor, it's almost always at adjacent segment. Here you can see a patient that was operated front back, but all of their hardware is at the levels above and below, and if they progress disease, as they did here, they lose fixation, and so we had to go to a very long construct. We've done this for years, but we had a big experience with percutaneous pedicle screws for patients with instability who didn't need a decompression and had about a 2% failure rate. And so we realized that in the era of fenestrated screws or cement augmentation of screws, that in these open separation surgeries, we could start to go short if we augmented them. And we've done about 120 cases now, and we think our fixation failure rate's about 2%. So this may be a very effective strategy for trying to minimize the surgery we do in these patients. We're now going to percutaneous screws in these patients, and for some that are candidates, we'll do tubular decompressions, again, to try to reduce the morbidity in this patient population and get them to early radiation. My partner, Ori Barzilai, is working on endoscopic resection of tumors, and we think ultimately we'll be able to get into the epidural space with an endoscope. Here's an osteoid osteoma that he took out purely endoscopically, so we're working towards that for the metastatic population as well. And as Pat talked about earlier, the endoscopic techniques for benign tumors are really remarkably effective. We have a Da Vinci robot program now. We've taken out about 12 chest or retroperitoneal schwannomas with the Da Vinci robot, which is really an effective way to get these tumors dissected. And they're now very interested in working with us for other applications for tumors, including developing drills, but these are really quite remarkable. And the question is, can we eventually get into that epidural space and do it robotically as well? One of the great advantages of radiosurgery over conventional radiation is that it reduces wound complication rates. The worst population are patients who get pre-op radiation and then have to go to surgery, and in looking at that population with conventional external beam radiation, we had a 17% risk of wound dehiscence versus 6%. But if you work really hard, especially in the primary tumors now where we're doing a lot of neoadjuvant, you can spare your operative quarter and reduce that even lower. And the problem in this population is if they get a wound infection or dehiscence, you have to turn local rotation flaps, which certainly increases the morbidity, but we had 100% salvage of our wounds and our hardware in this setting. So in our GNOMES framework, patients with radiosensitive tumors, regardless of the degree of cord compression, can still go to conventional external beam radiation. If they have radio-resistant tumors with minimal or no spinal cord compression, they go straight to stereotactic radiosurgery. If they have radio-resistant tumors with high-grade cord compression, we do this really simple separation surgery, followed by stereotactic radiosurgery to get local tumor control. Instability, as we talked about, is a separate assessment. If they're unstable based on the SINS criteria, they need some kind of stabilization. And everything is predicated on what they can tolerate from a systemic disease and medical comorbidity standpoint. So here's a 66-year-old with a history of renal cell, has a 3-week history of what we call biologic back pain, which is night or morning pain that resolves over the course of the day and does not denote instability, has acute onset of weakness, Asia C, less than 3 out of 5 in the lower extremities, and has this tumor with very high-grade cord compression at T10, has significant medical history of chronic renal insufficiency. Stomach work actually showed the renal cell going into the renal vein, pulmonary nodules, and an acetabular fracture. So if we do our GNOMES assessment in this patient, patient is myelopathic with high-grade cord compression, SCC3. The tumor histology renal cell is very resistant to conventional external beam radiation, which is the only radiation we can use in the setting of high-grade cord compression. Mechanical instability, the patient has a SIN score of 4, so it's stable. And then based on the assessment of both medical oncology and the internist, the patient can tolerate anything. So in this patient population, right, high-grade cord compression, radio-resistant tumor, this patient would be put on high-dose steroids. It's renal cell, it'll benefit from a preoperative embolization. We would do this really simple separation surgery with circumferential disease at the time where we're using P32 plaques to clear the posterior dural margins, but with newer techniques we can actually treat circumferential epidural disease with radiosurgery alone, and then we take this patient to radiosurgery to get local tumor control. Thank you very much.